Metoprolol, propranolol, carvedilol, atenolol. If it ends in LOL, it's a beta blocker, a class of drugs usually prescribed to treat high blood pressure. And while tens of millions of people benefit from these drugs in modern day, the invention of the very first beta blockers completely changed how developers approach drug design. So in today's video, I'll tell you the story of how scientists created the first beta blockers, then how doctors started prescribing them for blood pressure, and finally, how they got their role in modern treatment. But first, let me introduce our main character for the story, a Scottish doctor named Sir James Black. Black started medical school in 1946 in Scotland, took a teaching job in Singapore the next year, then came back to Scotland in 1950 where he got a job at a veterinary school in Glasgow. But along the way, a tragedy during medical school inspired him into a career in pharmacology research. As he tells it, quote, "As a young medical student, I watched my father die suddenly after a minor car crash. My father had angina for many years, and I remember wondering if it was enhanced sympathetic drive to the heart, the reaction to fight, flight, or fright, that had precipitated ventricular fibrillation. As a result, James decided to spend the next part of his career studying the relationship between stress, heart attacks, and angina. To give you some background, when your heart beats faster, like when you're excited or exercising, the heart muscle itself consumes more oxygen. When that muscle tissue doesn't get enough oxygen, it can manifest itself as a chest pain called angina. And certain factors predispose you to angina, like if you've got stiff, narrowed arteries from cardiovascular disease, it's more likely your heart muscle won't get the oxygen it needs. But at that point in history, doctors only had a few options to treat it. The main one was to widen blood vessels with nitroglycerin. Nitro relaxes blood vessels, which causes them to expand and allows them to keep delivering oxygen to the heart. But they also caused headaches and flushing, so there was room for improvement. Black decided to use an entirely different strategy. Instead of trying to increase oxygen delivery to the heart by increasing blood flow, he'd reduce the amount of oxygen the heart needed. And one of the ways he could do this was by finding a drug that kept heart rate low. So he decided to focus on the effects of adrenaline, a hormone you're familiar with thanks to its role in the fight or flight response. The problem with that strategy is that adrenaline affects just about every organ in your body. So Black started searching for something more selective, a way to block adrenaline's effect specifically on the heart. And in 1956, that search led him to this textbook, Pharmacology in Medicine, where he came across a controversial chapter about adrenergic drugs. Adrenergic meaning related to adrenaline. But the thing that made it controversial became the inspiration for the discovery of beta blockers, so we need to rewind a few years. In the first half of the 20th century, physiologists started to imagine drugs and hormones as chemicals that bound to specific receptors, kind of like locks and keys. How well a molecule binds to its receptor is called affinity. For example, the hormone adrenaline binds to adrenaline receptors, so we say it has an affinity for that receptor. It doesn't have affinity to, say, insulin receptors. Then, once a receptor is stimulated, it causes a physiologic response. Like when insulin binds to an insulin receptor, it stimulates the cell to take in glucose. The extent to which a molecule causes that response or responses is called efficacy. And by the 1940s, scientists had already used this new receptor theory to design clinically useful medicines. But the theory itself remained more of an interesting concept than an accepted fact. And while physiologists had some clues that adrenaline receptors existed, there were some unanswered questions. Like earlier scientists had noticed that adrenaline causes two broad categories of effects. Those could be either excitatory, causing things like increased heart rate, higher blood pressure, or vasoconstriction, the tightening of the smooth muscle around blood vessels. But it also had inhibitory effects, causing things like vasodilation, which is the relaxation of the muscle around blood vessels, causing them to widen. The most popular explanation for this phenomenon was a concept called sympathin theory. The idea was that there were chemicals called sympathins that would bind to adrenaline and turn it into a form that would cause those excitatory and inhibitory functions at the cellular level. But a scientist named Raymond Ahlquist wasn't convinced. Instead of two different forms of the hormone, he hypothesized that there were two types of adrenaline receptors, excitatory and inhibitory. To test this, he used a drug called isoprenaline, what's also called isoproterenol. He thought it would stimulate inhibitory adrenaline receptors. But when he tested it on different tissues, it led to both. It relaxed the airway while increasing heart rate. So he changed his language and proposed two new classes of adrenergic receptors, alpha receptors and beta receptors. He hypothesized that when the alpha receptors were stimulated with adrenaline, he didn't mention noradrenaline, they caused things like vasoconstriction. Meanwhile, stimulating the beta receptors increased heart rate and relaxed the smooth muscle around the airway. While Ahlquist was mostly right, it was controversial for the time, so he couldn't get published in the main pharmacology journals. According to a retrospective article by Ahlquist, the only reason his work was published at all was because he was friends with the editor of a smaller physiology journal. But Ahlquist's explanation also found its way into a textbook, Drill's Pharmacology in Medicine. This is the book that James Black referenced when he looked for ways to block the effects of adrenaline, and this was the game changer. Black realized that he could slow down heart rate and prevent angina by finding a beta-adrenergic receptor antagonist, what will become known as a beta blocker. So in 1958, he went to the pharmaceutical division of a UK company called Imperial Chemical Industries, or ICI. He told them the idea and asked for funding. ICI was one of the few pharmaceutical companies in the world studying cardiovascular drugs at the time, so instead of a grant, they offered him a job. Black accepted. So now it's June of 1958, and the beta blocker project could finally get going. Black and his colleagues had one solid lead with isoprenaline. Ahlquist's experiments had shown that it bound to beta receptors, so if they could modify it to block the receptors rather than stimulate them, they might have their beta blocker. Now, right before they'd gotten started, two scientists at Eli Lilly published experiments on something promising. An analog of isoprenaline called dichloroisoprenaline, or DCI. It's pretty much the same molecule, but with two chlorides attached, hence dichloro. The team was looking for a long-acting bronchodilator, or a drug that opens the airway. And they found that DCI had a different action from isoprenaline. DCI didn't relax the airway, but when given on its own, it could lower blood pressure and heart rate. So in their April 1958 paper, the Lilly scientists proposed that DCI blocks the effects of adrenaline by binding to an inhibitory adrenaline receptor. They didn't use the alpha and beta receptor terminology. Then later that year, the team of Moran and Perkins did similar experiments with DCI. But unlike the Lilly scientists, they leaned into Ahlquist's alpha and beta receptor theory and proposed that DCI was an antagonist of the beta-adrenergic receptor. Simply put, DCI was a beta blocker. Unfortunately, it wouldn't be the best fit for a commercially available drug. DCI has something called intrinsic sympathomimetic activity. It binds to the same receptor as adrenaline, which blocks the full efficacy of adrenaline, but it still stimulates the receptor a little bit. I use the analogy that if it were a light switch, it wouldn't be an on or off, it would be more like a dimmer. It turns on the light, but it keeps it from shining full blast. So, Black is keeping up with all this research and realized that neither isoprenaline nor DCI would be the best fit for a beta blocker. But maybe an analog of DCI would. In 1960, chemists at ICI modified DCI by replacing its chlorinated ring with a naphthyl ring, creating a new compound they called propranolol. But when they tested it, they got good news and bad news. The good news was that propranolol slowed heart rate and reduced the force of the heart's contractions, which lowered the heart's oxygen demand and prevented angina during exercise. This meant that Black's beta blocker concept was working as expected. The bad news was that toxicology studies showed that it caused tumors in rats and produced dizziness and nausea in humans. Nevertheless, ICI kept studying it and eventually released it as Alderlin in 1963, but only recommended it for emergency use. Over the next few years, Black grew his team of chemists and physiologists and made little tweaks to chemical structures in the hopes of finding something better. And it finally paid off in 1964, when his colleagues developed Propranolol. ICI and its marketing partners sold it under the trade name Inderal. Now, here's the twist. Black intended beta blockers to treat angina. And they did, but these days we're more familiar with beta blockers as a treatment for high blood pressure. And to understand how that shift happened, I need to give you some backstory, because historically, doctors thought that high blood pressure was just a byproduct of old age. They even called it essential hypertension because they thought it was essential for health. But that changed for a few reasons. The first was that after World War II, rates of strokes and heart attacks increased in the US, so doctors got more interested in understanding the causes of cardiovascular disease. Around the same time, the pharmaceutical company Merck started selling a diuretic called chlorothiazide as a treatment for swelling. And while it seems unrelated, they noticed something interesting. When patients urinated more, their blood volume decreased, which lowered their blood pressure. The connection between those two things came from a giant epidemiological study called the Framingham Heart Study. Initial results from 1957 pointed to a correlation between high blood pressure and cardiovascular disease. And now that doctors had these new diuretics, they started using them as a way to bring down their patients' blood pressure and reduce their risk of cardiovascular disease, usually in combination with their existing medications. The CDC eventually confirmed that lower blood pressure did indeed lower one's risk of stroke. So by the end of the 1950s, doctors were starting to treat hypertension as a risk factor for cardiovascular disease, which meant that blood pressure medications were about to be in high demand. This is where beta blockers come back in. See, blood pressure is the force exerted by the circulating blood against the walls of the arteries. First-generation beta blockers like propranolol lower that pressure by bringing down heart rate and reducing how hard the heart muscle contracts. As a result, the heart pumps less blood per minute, which lowers blood pressure. So while Black originally focused on angina, scientists also tested these drugs as blood pressure medicines, especially since doctors wanted an alternative to thiazide diuretics that didn't make their patients pee. Results from a small trial published in 1964 showed that usage of propranolol lowered blood pressure in people with hypertension. Later that year, scientists reported similar findings with propranolol, but over longer periods of time. Its use as a blood pressure medicine gave propranolol an even bigger boost in popularity, and turned it into one of the best-selling drugs in the world in the 70s. But propranolol and the first-generation beta blockers that followed still had an unwanted but predictable consequence. When beta blockers worked, they could constrict the airway, and that's problematic for patients with asthma or COPD. So after ICI introduced propranolol, the next challenge was to find a beta blocker that would lower blood pressure and treat angina, but without the lung stuff. We already knew there were at least two types of adrenaline receptors, alpha and beta, but the evidence was building for the existence of subtypes. And in 1967, a team of scientists provided evidence for multiple types of beta receptors, beta 1 and beta 2. Beta 3 was found later by different scientists in 1989. Beta 1 receptors mainly affect heart muscle cells, while beta 2 receptors are more widespread around the body. They mainly affect the smooth muscle around blood vessels and airways. Beta 3 receptors are mainly found on fat cells called adipocytes, but they're not super relevant for this video. There are also alpha 1 and alpha 2 receptors and subtypes within the alphas, but it gets overwhelming real quick, so we'll keep it high level for now. Propranolol and the first generation of beta blockers are non-selective, meaning they bind to both beta 1 and beta 2. The ideal second generation of beta blocker would be selective for beta 1 receptors. That doesn't mean the drug binds exclusively to beta 1s, just that it has a greater affinity for beta 1 receptors over beta 2s. With all their years of experience, it's no surprise that a duo of scientists at ICI found something pretty quickly. In 1968, the duo of Dunlop and Shanks, both of whom worked with Black, published their results on a new compound that would become known as Practolol. The 1968 paper describes all kinds of tests on different animals' tissues, but the main takeaway was that Practolol slowed down heart rate and didn't constrict tissue in the airway like propranolol could. ICI launched it in 1970, but it caused some weird eye disorders, so it was taken off the market after a few years. But they were already working on a different selective beta blocker called atenolol. That one came out in the UK in 1976. Meanwhile, other pharma companies were following with their own beta blockers. West Germany's Merck tweaked the structure of atenolol and came out with a beta 1 blocker called bisoprolol. And in 1969, a Swedish company called Astra Hessla synthesized a new drug called metoprolol. The earliest version was metoprolol tartrate, which is a fast-acting version, but they later developed metoprolol succinate, which is an extended-release version. Hessla started selling it in Sweden in 1975, then in the US in 1978, under the brand name Lopressor. The metoprolols would go on to become some of the most prescribed medicines in the world and are currently the most popular beta blockers. As of 2024, over a third of beta blocker prescriptions in the US were for metoprolol succinate. So now, in addition to the non-selective first generation beta blockers, we've got the cardioselective second generation. But then in the early 70s, scientists noticed a quirk in a new beta blocker called labetalol. It blocked beta 1 and beta 2 receptors like the first generation drugs, but it also blocked alpha 1 receptors. So now you've got a lowered heart rate and weaker contraction force from the heart muscle, but because it also blocks alpha 1 receptors, it relaxes the smooth muscle around blood vessels. This was the debut for the third generation of beta blockers. See, by blocking alpha 1 receptors, they affect a determinant of blood pressure called peripheral vascular resistance, or PVR. This is the resistance conferred by the blood vessels themselves. Stiff, constricted blood vessels or diseased vessels provide more resistance, while wide, dilated vessels offer less. the third-generation beta blockers allowed the vessels to widen a bit more easily. Over the years, we'd get more third-generation beta blockers like carvedilol, which got FDA approval in 1995, and nebivolol in 2007. But newer doesn't necessarily mean better for everyone. Carvedilol gets used more often by heart failure patients, whereas the second-generation beta blockers get used more often for run-of-the-mill hypertension. As these new drugs are coming out, people are making the connection that since beta blockers lower heart rate, maybe they'd also help with the physical manifestations of general anxiety too. High heart rate, fast breathing, that kind of thing. The FDA never officially approved beta blockers for this indication, but some doctors prescribe them off-label for anxiety anyway. And I didn't know this before researching for this script, but more and more people are taking beta blockers for stage fright, or like as a way of calming down before public speaking. And of course, the other group of people who started taking beta blockers were athletes, especially archers and shooters. They used it as a performance-enhancing drug to help them chill out and relax and shoot straighter. That's why beta blockers are banned by the World Anti-Doping Agency for those sports. So, the first beta blockers come out in the 1960s, and it seemed like they would accomplish their original goal, to prevent angina and reduce blood pressure. But clinical trials don't always have the same conclusion as long-term studies. So starting in 1977, the American Heart, Lung, and Blood Institute sponsored one of the most ambitious trials up to that point, the Beta Blocker Heart Attack Trial, or BHAT. Now I know their artwork is super subtle here, but this is a bee wearing a hat for BHAT. In the trial, researchers recruited thousands of men and women ages 30 to 69 who had had at least one heart attack, then assigned them to take either propranolol or a placebo. Then, over the next 27 months, the researchers kept track of how many people in each group died. And the results were clear. Beta blockers decreased mortality from cardiovascular disease and all-cause mortality compared to a placebo. It was such a pronounced difference that the study was canceled 9 months ahead of schedule. They had already found the answer to their hypothesis. That study focused on people who had already had heart attacks, and newer blood pressure drugs have come out since then, like ACE inhibitors and calcium channel blockers. So the question became, how good are beta blockers compared to these other options, and where do they all fit in clinical practice? This is where Cochrane reviews become super useful. These are very specific literature reviews in healthcare and health policy, and for a non-doctor like me, they're also useful big picture reviews for the evidence behind practice. And there are 3 that I want to show you. One of the earliest Cochrane reviews to look at beta blockers' effect on blood pressure came out in 2007. It was updated in 2012 and again in 2017. For the 2017 edition, researchers compiled 13 studies that looked at beta blockers given as first-line treatment, so patients who had high blood pressure and this was the first drug prescribed. After compiling data from the tens of thousands of participants, they concluded that beta blockers were either as good or worse than other classes of drugs at preventing heart disease or death in people with hypertension. And while they prevented strokes a little better than placebos, patients were more likely to quit beta blockers because of side effects. In their conclusion, this review supported the practice of prescribing something else instead of beta blockers for most people with high blood pressure. But again, that's as first-line treatment, as a way for someone with high blood pressure to prevent cardiovascular disease. A 2019 Cochrane review asked a different question. Does the evidence support using beta blockers to treat acute heart attacks? They concluded that people who got beta blockers didn't necessarily have a better chance of surviving the acute heart attack, but they did have a lower risk of getting another heart attack right away, and they probably had better survival in the long term. So then, looking long term, a 2021 Cochrane review looked at beta blocker use for folks who had had a heart attack in the past but didn't have heart failure, and compared their outcome to patients given placebos. So unlike the last patient population, this group wasn't in the acute phase of a heart attack. They concluded that giving beta blockers in this situation reduced the risk of getting another heart attack and all-cause mortality. And maybe it lowered the risk of cardiac events and death from heart disease. So these Cochrane reviews come out in addition to all the other research in different patient populations and situations, and that leads professional organizations to issue their own guidelines, kind of like official recommendations for clinicians. The most recent clinical guidelines in the US came from a 2017 report by the American College of Cardiologists and American Heart Association. They recommend using non-pharmacologic treatment first, like diet, exercise, and stress management. But when drugs are appropriate, the guidelines recommend using other blood pressure medicines as first-line treatment for most patients. Beta blockers may be more appropriate when the patient has heart failure or when the patient already has cardiovascular disease. In 2024, the European Society of Cardiology followed suit. They recommended lifestyle modifications for at least 3 months before trying a drug, but from there, they say that since all the classes of antihypertensives have similar outcomes, it's the doctor's call. The important thing is that blood pressure comes down. So while doctors used to think that beta blockers were a good first step treatment for anyone with hypertension, they eventually learned that there are better first choices out there. Beta blockers are still useful, but we have a more nuanced understanding than we did back in the 1960s. Nevertheless, there's still some clean takeaways we can get from the story. Number 1. Propranolol fundamentally changed how drugs were designed. I've talked about this in other videos. You can go check out the aspirin video for a good example, but the biggest pharmaceutical makers of the late 19th and early 20th centuries were chemical producers. As a result, drug design started with, let's tweak this existing drug and see if it works for something else. The difference with James Black was that he started with physiology in mind. He identified a medical problem, angina, then he studied the underlying physiology and found that decreasing heart rate might work as a treatment. That's what inspired him to block receptors that would increase heart rate. It was the beginning of a concept called rational drug design. You start with the biological target and then find a chemical that matches it. After propranolol, Black used the same rational drug design strategy to create cimetidine, a popular antihistamine and ulcer medication. But the underlying idea of rational drug design would become a central idea of pharmacology going forward, right? We study how bacterial cell membranes are different from ours and design antibiotics to exploit that difference. We study how breast cancer presents a specific antigen, then design a monoclonal antibody to target that specific antigen. We start with the physiology, then design the chemistry around it. Second takeaway, sometimes different branches of science influence each other. Like the fact that beta blockers worked was evidence for receptor theory. Pharmacology influenced physiology. It was a total coincidence that Black picked up this book and interpreted his work through the lens of Ahlquist theory instead of something else. According to Black, quote, "There is equally no doubt that my own work, begun in 1958, would not have started but for Ahlquist theory." As a result, the success of beta blockers not only popularized Ahlquist's theory of alpha and beta receptors, but the validity of receptor theory itself. The accidental legacy of beta blockers doesn't come from their clinical impact necessarily, but from how they sparked a focus on rational drug development. Now, before you go, I make all these videos by myself without generative AI. Each video takes anywhere from dozens to hundreds of hours of work. So if you're able to support the production of these videos, consider becoming a member of my Patreon. I've got a handful of exclusive videos on there, like the story of how antihistamines turned into the first antipsychotic drugs, and the story of anthrax as a biological weapon. But mostly, by supporting me on Patreon, you're helping me produce high-quality, well-researched videos that aren't AI slop. So if you're interested, head to patreon.com/corporus. Otherwise, here's some other videos of mine to watch. Thanks for watching. Take care.